this morning we have Dr. Bhagavath here to present Grand Rounds. He is a professor in the REI division here, as we all know, and he's also serves as the medical director of Generations. His main interests are in improving the management of anomalous development of female internal and external genital organs and innovative and novel treatments for fibroids. So we are very excited to have him here to present this morning.
Thank you, Laura, for this nice introduction. So the title of my presentation is Reproductive Surgery, Past, Present, and Future. I am a PI for a few clinical trials. The structure of the presentation, I have divided into sort of various regions of the pelvis, quite easy as gynecologists for us, very narrow path. Peritoneum, ovary together, tubal, and for a very specific reason, I would be talking about the tubal aspects last, the uterine, cervical, and vaginal aspects of reproductive surgery. I am a history buff. I love history, especially medicine. And I don't know how many of us know that Hippocrates is actually Hippocrates II. He was the grandson of Hippocrates I, and his father was a physician as well, and his sons were physicians as well. It's a long lineage of physicians, and of course, his contribution to medicine is renowned. What we don't know, or we should know, is that he was the first to endoscopy. This is 2,500 years ago, and he did proctoscopy even then. So he was the first to do actually any form of endoscopy. Another 1,500 years later, Abu Qasim, al-Zarabi, as he is variously called, really amazing physician. Even though of Arabic origin, he actually practiced in the southern part of Spain, and he has tomes written. He was well regarded in his time for his knowledge as well as his teaching specifically. And one of the things that he came out with was the vaginal speculum. So almost 1,500 years before a second innovation in endoscopy occurred. And the light source, which is really always the problem, was by use of a handheld mirror. So examination had to be done in broad daylight, and there had to be a source of sunlight so they could direct the light into the vagina to diagnose anything. And another 700 years passed before any sort of advancement in endoscopy occurred. You can see that within a span of 200 years, which when you consider 1,500 plus 700 years, quite a quick turnaround, we started having some movement in terms of bringing it inside the house. So shielded lanterns, light conductors, et cetera, But then in the last 100 years, the advancement has been really phenomenal. You can see the pace of growth and improvement and innovation. From diagnostic in the first 30 years of the last century, it moved on to surgical aspects. And one thing I would point out here, a few things, those who are interested, Sem, I don't know if you can see the, you can't, okay. All right, so Sem, the 1963, he was almost hounded out of practicing for his advancements. Sem practiced in Germany. He came up with so many innovations, but his license was taken out. He was being sued. It was just a horrendous time when innovation was being questioned and almost, how can I say, stifled is the correct word. So Sem notably made huge advancements against all odds at his personal peril. and we should learn about SEM a little bit when you have the time. The other thing I want to point out is gynecology led the way. Yes, these innovations occurred, but who put these innovations to work was gynecology. We started with operative laparoscopy from a standpoint of sterilizations and moved fairly quickly on. In 1989, Harry Reach did the first hysterectomy, which is a major organ, which is very different from the cholecystectomies and appendectomies that the general surgeons were doing. So we should take pride. And I personally take pride as an REI in that, along with those advancements, major advanced pelvic surgery was introduced. Laparoscopic surgery, that is, was introduced by REIs because of certain needs. So tubal factor was the predominant cause for infertility. So microsurgery was being evolved side by side with the innovations happening in laparoscopic surgery. And microsurgery necessitated use of some sort of magnification so that you can have some tissue handling, respect for tissue, as well as meticulous details to adhesion prevention. So from that point of view, both these innovations are happening side by side. The advantage of the laparoscopy, of course, was that magnification was also allowed at the same time, and decreased tissue handling was also possible when you're not opening the patient up. So together, that married the necessities together, and naturally, reproductive endocrinology and infertility specialists started becoming the advanced pelvic surgeries of the last part of last century. So moving on to different aspects and what has been happening in the past and what is currently the practice, and hopefully shed light on what the future holds for the various parts of the gynecologic anatomy. So endometriosis clearly is first and front and foremost in our consciousness when it comes to peritoneum as well as the ovary. Laparoscopic diagnosis was required in the past. In fact, most people, if you're academic, would look at this with disdain at anybody who's had a diagnosis of endometriosis without tissue or pathologic diagnosis. That is fast changing. Not the least of the factors involved in that change is the recognition that diagnosis is very often very delayed, up to a decade or more in many patients. And the reason for that is that insistence on having a tissue diagnosis for endometriosis. But again, all these changes happen with innovations and advancement in technology, and the ability with not only MRI to diagnose peritoneal endometriosis, which in the past we used to say, oh, you can diagnose endometriomas or adenomyosis, but you can't really diagnose peritoneal endometriosis. Not so true. We are able to diagnose that with MRI, but what's even more critical is to recognize that ultrasound diagnosis is becoming fast recognized as a gold standard. And with increased skill set, because that's the thing, with any innovation, you need to develop the skill set and propagate the skill set among the masses. So it on average takes 10 years for innovation or any new evidence-based treatment to become mainstream. So hopefully that pace will change and we will have increased ability far and wide in diagnosing endometriosis with just ultrasound and not MRI. The other thing that is happening is the MRI used to be so expensive, and not that it's not expensive at the moment, but nevertheless, it has become more accessible, I must say, to the vast majority of patients. And so that's also very helpful. So that's the main advancement in diagnosis itself, that endometriosis may not and need not be diagnosed with tissue-based diagnosis only. The other thing is in the past, and even currently, aggressive excisions with an aim to decrease disease burden at all costs. That includes bowel resections and ureteric resections, have been the key. Now, there have been centers around the world, especially Horace Roman, who literally does multiple bowel resection surgeries a day as a team. His team does that many surgeries. Himself has acknowledged that perhaps that's not the best thing to do. And the morbidity for these patients and the ultimate quality of life for these patients is not that much better. So the recognition again that, oh, what seemed logical need not necessarily be true in practice, and trying to find the best treatment for these patients to alleviate their suffering is fast becoming a reality. So the advancement in that regard is the lack of medical treatment until now. Any viable medical treatment. Lupron is only the alternative for those patients, and Lupron has such severe side effects. But now we have GnRH antagonists, other innovative new treatments are also coming to the forefront. Also, surgery was commonly performed as a treatment for infertility that within the last 2 decades has already gone away, with the recognition that IVF trumps that. Sadly for REIs, because from being kings or queens of minimally invasive advanced pelvic surgery, we quickly gave that up and now are not really running the show anymore. But the important thing about that is now surgery is less common for infertility. Surgery was only advocated for pain, and that has also changed, as I just said. So surgery now in the future will be delayed, and the current push is to advise patients to have a single surgery, but a definitive surgery in their lifetime, rather than the repeated surgeries that they have for endometriosis as of now. One other thing that we have recognized is that bilateral ovarian cystectomies, aggressive cystectomies for endometriomas, can profoundly affect the ovarian reserve of patients. So that's another reason why, as infertility specialists, we are a bit reticent to taking patients to surgery, as opposed in the past, we might have jumped at the chance. So as I mentioned, colorectal surgery most likely will be sparingly used. Certainly ureteric involvement, and if it is stricture, no choice but to resect and reanastomose in those circumstances. It is entirely possible in the next 15 to 20 years, with the pace of development of alternative forms, not just pharmaceutical agents, but other antibody-based treatments, that we may have a less surgery-heavy and more medical-oriented treatment for endometriosis. Polycystic ovary syndrome, we are in the neck of the woods of where this was first diagnosed. Again, I don't know how many of the residents know that the treatment for PCOS was a serendipitous discovery rather than a deliberate understanding of how it works. We still don't know how it works, for that matter. Almost 100 years from the time it was discovered, 88 years now. So when Stein and Leventhal in Chicago first described the condition, they noticed that these obese, hirsute women had on laparotomy these enlarged ovaries, which when sectioned, because they were enlarged, they took a wedge biopsy, which is a common thing in those days. Anything you want to biopsy, you take a wedge out of it. So they did a wedge biopsy, and they noted that there were multiple follicles in this. Instead of follicles, they saw cysts, and so it was called polycystic ovary syndrome, which, as you know, is a misnomer. But what is interesting is their observation that these patients subsequently started menstruating when they were not menstruating until that time. And so the treatment to do a wedge resection to allow patients to resume their menstrual cycles. However, very quickly, soon after 1935, in the 50s, Clomid was discovered, and the recognition that Clomid overcomes that. They don't have to have a laparotomy and a wedge resection. So Clomid started getting used for ovulation induction and resumption of menstruation in these patients. So until laparoscopy came to the fore, which is another 30, 40 years later, at which point people decided to go back to the roots and say, hey, instead of wedge resection, what we are doing is destroying the ovary a little bit. Let's just do the same thing with some diathermy. So use monopolar energy, and you go in and basically checking the temperature in a meat, you insert these needles and do 10 to 12 punctures on each ovary. And clearly that allowed for the resumption of menses as well. However, it still is invasive, as one can imagine. And there have been multiple studies that have looked at the efficacy of it. Some European studies have shown that a single ovarian, what is called ovarian drilling, which as a terminology evokes horrible images in your brain, results in up to 10 years of regular menses after the treatment. One thing, of course, is the observation with AMH being used to consider the ovarian reserve, that AMH decreases after such treatment, and the fear that we are decreasing the ovarian reserve of these patients. But what is really happening is these patients have very high AMH levels, which I'm sure you are aware, and the resulting decrease is normalization rather than a decrease in their overall ovarian reserve. And meta-analyses have shown that it's not statistically significant. And in terms of ovulation, 2 separate meta-analyses have showed that there is no difference between ovulation induction and laparoscopic ovarian drilling. So what is on the horizon is, instead of doing laparoscopy, doing transvaginal ovarian drilling, and Dr. Cooney is going to be doing a study soon in our clinic on that. So we are going to be one of the sites doing transvaginal ovarian drilling. In case you wonder that that's a new thing, it's not. It was first described in 2001. So it's only 23 years in the making, but hopefully that'll come soon. And if it is true that these patients have long-standing alleviation of their symptoms, then that is a great treatment. It's outpatient treatment, then they will have, instead of taking medications for a long period of time, even if it is ovarian contraceptive pills, you would rather avoid that if they don't need to be on that. Of course, if that's what they like to do, it's safe enough. But if they don't need to be on that, if they can resume menses and protect their endometrium that way, that is a great thing for them as well. Ovarian transposition and suspension has been long practice, well established for moving the ovaries out of the radiation field. But what is new is in those patients undergoing laparoscopic surgery for stage 4 endometriosis, for example, and you want to prevent the adhesion from occurring again, having the ovary suspended, not transposed, not quite tunneling it through the peritoneum and getting it above the pelvic brim. That is not the goal here. The goal is to bring them out of the pelvis into the anterior abdominal wall, thereby preventing them from adhering into the ovarian fossa and the cul-de-sac. So meta-analysis again of 8 trials, significant decrease in post-operative adhesion. So after any significant adhesiolysis, it may be worthwhile suspending the ovary. Not with a permanent necessarily suture, it's just to allow the healing to take place. So if it is a permanent suture, then it has to be removed in 1 to 7 days. Or if it is absorbable suture, then hopefully that will dissolve in a small time. The next innovation is in ovarian tissue cryopreservation and transplantation. Again, not really new, but what's new is how it is definitely moved from the realms of um, experimental procedure to mainstream now. Oocyte cryopreservation for a long time was an experimental procedure, but that since has changed and it's now mainstream, and so has ovarian tissue cryopreservation. All women regain their endocrine function and their piece of ovarian cortex is reimplanted. So the idea here is you go in and take out pieces of the cortex, small, a few millimeters thickness cortical tissue is removed before they undergo radiation or chemotherapy. And after they are in remission, you go back in either laparoscopically or robot or open. Most people do it laparoscopically. You tunnel the area in the what's remaining of the ovaries or ovary and insert these tissue in there. And amazingly, they take root and they start functioning again. So the live birth rate after such procedure is 25%. And so even after chemo, that is, I'm talking about we all would like to either do oocyte cryopreservation or ovarian tissue harvesting prior to the first chemotherapy. But what has been shown is that even after they have had chemo, if time is short, and as you know, oncologists are always like, we need to just start the chemotherapy yesterday, so there's very little time. Even after 1 or 2 cycles of chemo, you can still go ahead and remove ovarian tissue, and it's still viable and can result in assumption of ovarian function afterwards. So what is still experimental and possibly would be available mainstream is whole ovary cryopreservation. Women have had transplantation of whole ovaries, but not after they are cryopreserved. So in identical twins, again, it has been clearly demonstrated they could remove the ovary from one twin and transplant it to the other twin, resulting in normal ovarian function and live birth. So that has been proven. But what is still experimental, and I am really hopeful would actually become mainstream, is freezing the ovary, doing the chemo, and then transplanting the whole ovary at a later time. And certainly that I think is going to occur in the near future. Moving on to the uterus, of course, uterine leiomyoma, one of my passions. Current consensus is we don't know. So despite all this work, all these years, despite the fact that it's the most common condition that affects the uterus, the biggest problem we have is a lack of an animal model. All science, innovation, including uterine transplantation, started with animal work. Moving on to the humans, with uterine leiomyoma, you do not have an animal model. Humans are unique in having uterine fibroids. No other animal has it, develops it naturally. There are certain animal models, of course, but after induction, they are knockout and other genetically modified mice. But the problem with those is it's still not the same. They don't, these fibroids don't behave. The most famous animal model is the Ika rat, and it's still a far cry from the real pathology in humans. And what is sobering is this review of all the guidelines from various societies around the world. So it's an interesting, if you can call it a systematic review of recommendations from around the world. There were 166 separate recommendations from different agencies, and out of those, and these are for fibroids, okay, uterine fibroids, only 3 had consensus, and out of that, only 1 pertained to surgery. Why? Lack of evidence. So surgery for non-infertility reasons, without doubt, MIS is superior. It's decreased pain, decreased fever, and a hospital stay as opposed to open surgery. That's the one surgically proven information we can share. Otherwise, almost everything has very poor controls. The studies are poorly done. Naturally, then we don't have the confidence to recommend. In terms of the one consensus, not for surgery, but what is happening with infertility is if it is a submucosal fibroid, clearly it impacts fertility. Beyond that, and also if it is a subserosal fibroid, it absolutely does not impact fertility. When it comes to intramural fibroids, very, very confusing. We are not sure. What is on the horizon, not necessarily on the horizon, what may become mainstream, and I know that we offer that right here in our hospital, is radiofrequency ablation of uterine fibroids. It could be laparoscopic or transcervical. And I just came back from Nashville AAGL, and they are advocating a transvaginal approach using, just like we do egg retrieval, using a 17 gauge needle, the same needle, but the instead of the 17 gauge goes through the ultrasound guidance and goes into the individual fibroids and uses microwave as opposed to radio frequency to cause ablation. What we don't know is we don't have much long-term studies. What's the efficacy? What is the chance of recurrence of the same fibroid? With surgery, we know the fibroid's removed and any recurrence is from new fibroids or new growths, as opposed to here, if you don't completely ablate and if there are few cells in the periphery that are left behind, would that fibroid continue to grow? And also, how much of a bulk symptom relief is obtained after this? When patients have bulk symptoms like urinary incontinence of frequency, are you able to decrease that, or even just pure pressure? The current evidence is that on average, there's a 1/3 shrinkage, which goes hand in hand with uterine fibroid embolization as well, in that there is roughly 1/3. The lucky patients can have more, the unlucky ones, not even that. So that is the biggest problem with that. From a perspective of decreasing abnormal uterine bleeding, that definitely 5 out of 6 patients have symptomatic relief from that. So if a patient has predominantly uterine bleeding symptoms as opposed to bulk symptoms, then these are great alternatives for them to consider. Adenomyosis, on the other hand, is very challenging in terms of the symptoms, pain, abnormal uterine bleeding, infertility, RPL, the same gamut of symptoms that are associated with fibroids as well. The difference is that the surgery is quite involved unless it's focal. Even focal adenomyosis, the removal can be more challenging than a fibroid. And the reason for that is the tissue is very brittle. So if you put a tenaclum on to gain traction, it'll just come right through. You won't be able to apply traction as you do with a fibroid. So you really have to dissect into the uterus as opposed to dissecting the fibroid out of the uterus. So that's a big difference in the surgical approach. But when it is diffuse, it is even more challenging. Multiple surgical treatments have been advocated. The classic, which is just like any fibroid, make a transverse or vertical incision, and then you dissect it out, which is helpful in focal adenomyosis, but not in diffuse adenomyosis. But the double flap, triple flap, H incision, asymmetric dissection, so many different surgeries, all mainly out of Japan, surprisingly, for some reason. All the innovations in terms of the different types of surgeries that come out of different researchers from Japan. Their numbers are interesting and impressive. However, we don't have correlation. We don't know how much of these very radical surgeries really help in terms of symptom relief as well as infertility in these patients. So it remains to be seen whether surgery will remain or not remain surgery will advance to be the mainstream treatment or still remain one of the less applied, and more medical treatments may again become favored as opposed to surgery. So things that are in the future for adenomyosis and hopefully for endometriosis as well, by translation, is antiplatelet treatment, microRNA, and of course, what's interesting is radiofrequency ablation and microwave ablations are being reasonably well studied now, even though long-term effects we are not sure about, as I alluded to earlier, with respect to adenomyosis, not so. So the difference is with fibroids, you have a pseudocapsule, you try to confine yourself within the pseudocapsule. With the adenomyosis, you have myometrium intervening. So adenomyosis is not just adenomyotic tissue there, you've got myometrium intervening there as well. So you're necessarily causing myolysis as opposed to radiofrequency ablation of a leiomyoma. So the myolysis will result in actual destruction of the normal myometrium, and how much that also involves the myometrium outside of the affected area is the question. So it is now being studied, now that radiofrequency is becoming mainstream for treatment of fibroids. People are moving into the realm of adenomyosis as well. And once again, as you can imagine, when it is a focal adenomyoma, it is much better treated with such modality. But if it is diffuse adenomyosis, for example, affecting the whole of the anterior posterior wall of the uterus or the whole of the uterus, anterior and posterior, how effective that's going to be and what the morbidity would be, we don't know. So those are the things that are on the horizon for adenomyosis. Comes to uterine anomalies, septum, the most common anomaly that we all take care of. The past is the Tompkins metroplasty. The question has always been, despite the fact that was described over 100 years ago, is to divide or not to divide. Do we even have to do? Why? There are women who have these septum and who deliver full term normally and is only incidentally diagnosed to have a septum at a later time. So if you assume that it causes preterm delivery or recurrent miscarriage, then how is it possible for these women to have full-term deliveries? The theory, and I have to emphasize, the theory is that it depends upon where the placenta is implanting. So if it implants on the septum, which is avascular, as we all know, the theory is then it results in miscarriage. On the other hand, if the implantation were to occur in the normal myometrium, then obviously that would continue to be possibly a full-term ongoing pregnancy. So to address this question, the European Consortium recruited over a period of 10 years, 80 women. So it was a really hard study for them to do, 5 different centers. And over 10 years, they only managed to recruit 80 patients. And the other problem that big was their classification system is very different from our classification system. What they consider as a septum, we would consider arcuate uterus. So those patients were included actually halfway through the trial because they were not recruiting enough patients. So they relaxed the criteria to include more patients. But in the end, the problem is, yes, they didn't show any difference in terms of improved live birth rate or decreased miscarriage rate. But the problem is the inclusion criteria and everything had become so loose. The criticism is profound, and as a result, I think we will never find an answer. Just like Women's Health Initiative study caused a big ruckus, but now we'll never really know because we won't do one more study like that, correcting all the mistakes that were there at WHI. Similarly, I don't think, knowing what we have learned in this, if you tell a patient, oh, you're having recurrent miscarriages, you have a septum, I think we'll randomize you into doing the surgery, which is relatively safe, or not. You agree to continue to try and get pregnant. that speaks to why you have difficulty recruiting patients for the study. And that also speaks to why we have such difficulty doing good randomized studies for surgery as well. On top of everything else, as opposed to medical treatments where the medicine is the same, and that's one aspect that is controlled. With surgery, the skill set of the surgeon, the type of patients, so many other factors are in play that makes it very hard to get very good evidence-based information to inform ourselves and the patients. So other uterine anomalies, bicornate uterus and horns, Strassman metaplasty was the other one that was advocated for recurrent miscarriages. And even today, we perform the surgery, although laparoscopically. But the indication is very clear. Patients should have repeated miscarriages, as opposed to uterine septum. With the bicornate uterus, the recommendations are very clear in that you don't attempt any surgery, surgical correction, or unification of the uterus unless the patient suffers repeated miscarriages, because the vast majority of patients do carry on and have pregnancies. The problem is, if you think about it, is like having unicornate uterus. So for unicornate uterus, there's no surgery advocated. These patients have two separate unicornate uterus. If you think about it that way, they have a 40% chance of having repeated preterm deliveries, and they have an increased risk of having miscarriages, but they have a 60% chance of having live births and full-term deliveries. So that trumps the fact that you have increased morbidity, even if you're doing laparoscopic surgery to unify the uterus. So for that reason, of course, again, there are no comparative studies, so there's lack of control as well to inform us that unifying the bicornate uterus is really helpful. So unless it is absolutely indicated from repeated miscarriages, you do not approach a Strassman metaplasty. As opposed to uterine horns, if they are non-communicating, even if they are non-communicating, because they have been shown, as long as there is a cavity, they've been shown to result in ectopic pregnancies. The advice is to remove non-communicating uterine horns to decrease that risk. Asherman syndrome, the bane of our existence. Hysteroscopic lysis of adhesion is classic. We always give these patients high-dose estrogen in the hope that we'll quickly seed that area and make the endometrium grow over it. The type of surgeries we do, again, controversies. Should you use surgery? Should you not use electrosurgery? Can you use laser? So many things are still up in the air. Again, for the same reason, no two adhesions are the same, no two fibroids are the same. And similarly, the scoring systems, in terms of studying it, you need to know how severe it is. The scoring, there are so many different scoring systems. There's the ASHRAE, there is the ESGE scoring system, there's the American Fertility Society scoring system. There's a March classification. You can go on. And so different investigators use different scoring systems, and that makes it difficult to compare apples to apples as well. In terms of preventing these adhesions from occurring, of course, different things we have tried. We've used a triangular balloon. The idea is that it will extend into the cornea and really distend the cavity and prevent the two surfaces from sticking together until the healing takes place. No studies to prove that it helped, to be honest. And unfortunately, the product was taken out of the market, and people now use the Foley catheter, which of course is even theoretically not ideal. It only distends the middle of the uterine cavity and not the sides. And very frequently, adhesions are on the sides. And so you are not really addressing the real problem. So now, over the last 10 years, really, more in Europe than here, but it is beginning to come here as well, use of these gels that set instantaneously. So instead of the balloon, the advantage of these is that it will really cover the entire surface of the uterine cavity, and therefore be even more ideal than the triangular shaped balloon, because there are two different sizes depending upon how big the cavity is. So it was better than the Foley, but it was not ideal. But these gels, theoretically at least, are ideal. Again, the big problem is to prove that they actually make a difference, and it is better than repeatedly going back every 2 weeks and cutting down newly formed adhesions, which, by the way, has been shown, at least in series, again, not in controlled trials, but in series, to help prevent recurrence of adhesions. That is, repeated office hysteroscopies and lysis of adhesions on a frequent basis until the adhesions resolve. What is interesting is that big studies, most of them from China, because they have the population to study, show that lysis of adhesions seem to help with a 2/3 chance of live birth after lysis of adhesions. What would be interesting is there are patients who have completely congealed cavity. You go in, you're at the internal loss, and there's nothing else, and you're recreating the cavity. And sometimes we are successful. One has had some great success, but oftentimes not. You see a patient with a completely obliterated cavity, you don't see the hope is not there in these patients. So for those patients, the dream, and there are some researchers working on it, is to have stem cells that can be infused in, the stem cells that will transform that cavity without any basalis layer, which would help regenerate. You need some basalis to allow for regeneration of the endometrium. And so the stem cell therapy, the hope is, will result in complete regeneration of the endometrium in a cavity that is so scarred. In the last decade, cesarean scar defects have been recognized. We have recognized cesarean scar defects as a problem, not as a problem. We have recognized that they are there and they are very common, but it was more a novelty. And you can say, oh, you have had C-section. I can see that on ultrasound. But in the last decade, the recognition is that it is not benign. It is not just an observation. It actually causes problems. Vaginal spotting, very classic, is this brown, dirty discharge that the patients have after the MNCs have stopped for a prolonged period of time. Dysmenorrhea, we don't understand why, but definitely associated with cesarean scar defects. Pelvic pain, infertility, again, has recently been recognized as definitely tied to it. And the theory is the fluid that this secretes goes into the uterine cavity and is actually embryotoxic. And finally, the ectopic pregnancies that we increasingly see in cesarean scar defects and the management of those. Should you treat these hysteroscopically or laparoscopically is an intense debate. I am in the school that believe that there is no single answer. Some believe that everything can be treated hysteroscopically, and others, everything laparoscopically. I am in the middle of that. I like the middle ground there. If there is at least 2.5 millimeters of residual myometrium between the bladder and the apex of the defect, and I tackle that hysteroscopically. And there's good evidence actually for that, because here you can study, you can look at the myometrial thickness after the surgery and show that the myometrial thickness has increased, which is mind-boggling. You don't go and suture it. All you do is remove that endometrium that's ectopically present in that defect, and just removal results in that myometrial defect close and increase of the thickness of the myometrium. So definitely a hysteroscopic approach is feasible and also safer and faster for the patients who are eligible. And those patients where the residual myometrium is thin and you have the risk of perforating not only the uterus, but the bladder, injuring the bladder as well, which, as you can imagine, the trigone sitting right there would not be a good thing. Then a laparoscopic approach would be the best. What's in the horizon for this? Actually, prevention. So people are looking at different types of closure. Clearly, the cesarean hysterotomy closure technique could contribute to this. Because again, we are not sure whether it does or not, but studies are ongoing to try and figure out if different closure techniques will decrease. It will not eliminate completely, but at least decrease the incidence of these defects in the future. Uterine transplant, very quickly, very well done, a testament to science being done the right way. As a concept evolved, first on paper, literally on a napkin in a restaurant in Australia, moved on to animal studies in Sweden, and finally, after proving that it works in animals, moved into human realm, and the first live birth occurred in 2014, almost 10 years now. And 2 years after the first live birth in the world, we had the first live birth here, Cleveland Clinic Foundation in the US. Certainly, there are some ethical guidelines that are needed here. And in 2012, before even the first live birth, as this was beginning to become a reality, Montreal criteria for the ethical feasibility was developed. And where are we now? We have multiple centers in the US offering this, and certainly around the world. The question is there a need? And there was recently a very good debate at the AGOS meeting in Chicago, where the 2 points of view that it is absolutely needed, and well, it is not, and it's really a fad, was proposed. And the truth of the matter is the cost, the sheer cost of it, not only from money perspective, but also if you look at the morbidity, the cumulative birth rate is awesome, 80%, really fantastic. But you look at the high incidence of preterm birth and respiratory distress syndrome in the babies, serious, I'm not talking about just some postoperative complications, serious morbidity of 18% in the recipients and 19% in the donor, makes one question as to whether this is mainstream and should we really be doing it just because we can. Cervical anomalies, complete uterine, cervical, and vaginal septum. If you look at the classic surgery, it is keep the cervical septum intact, and you go in from one side, make a hole through the other side. Very intricate, makes the infertility surgeons feel proud that they can do such intricate surgeries. Absolutely not needed. You can just divide that septum. It's like any other septum. It's not that they have two cervices. It's just a septum dividing a single cervix into two. And studies have shown that it is totally safe. These women don't have preterm deliveries or cervical incontinence because of that. So we can stop doing that, and you can just divide the cervical septum like you would the uterine septum. Cervical agenesis, on the other hand, very rare, but incredibly challenging, especially when somebody has a normal uterine body and they are menstruating and they have hematometra, and you know that you could, if only you can find a way to open that up, you could give these women a ability to retain their fertility, but creating a new cervix and maintaining the patency, both are incredibly challenging. But hopefully some innovation will occur in that realm as well in the future. Vaginal anomalies, vaginal agenesis is really the most important one that we take care of. McIndoe is classic. Unfortunately, the donor site is ugly. So, and also the morbidity associated with that. And also keratinized skin is not ideal as a vaginal mucosa. So people have tried the Frank's method, the original dilation method, but most patients don't have the how can I say, ability or motivation to press with, it is painful. I can imagine to press a mold into the perineum like that to elongate it. So Vacciati just makes it happen over 7 days instead of over 6 months. You have laparoscopic surgery, you put a bead into the perineum, and then you ratchet it up. You look at the images. I have never done this myself. Look like a torture instrument. They basically have this thing sitting on top, and you keep cranking it up, the pressure, and you cause a vaginal formation over 7 days. Again, cannot be easy. It's not easy. These patients are in-house, inpatient for that length of time. So other things have been explored. Vaginal buccal mucosa, clearly the scarring is inside, but still morbidity associated with that. Tilapia skin, interestingly, not just for vaginal, but for other skin grafts have been used quite effectively. So there is no donor site here, even if it is in the buccal area. So that is a great advancement, and that has been used. What is on the horizon is in vitro generation of the vaginal mucosa, and that will be the best thing for patients. So hopefully that will become mainstream soon as well. And finally, I saved the best for last, the fallopian tube. This is where the infertility surgeons started and honed our skills, because the attempt to save the fallopian tube. But before I go into the microsurgery aspect of it, linear salpingotomy, I want to make a plug for it. At least a couple of times I've operated the residents, nobody have heard of that or seen anybody do that. It's an attempt to save the tube in ectopic pregnancies. When the contralateral tube is normal, if you remove the tube or if you open the tube, the subsequent pregnancy rate is the same. So, in terms of intrauterine pregnancy and ongoing pregnancy. However, when the contralateral tube is diseased, contrary to your thinking, salpingotomy of this tube, if that looks okay, is definitely worth it, because that saves the ability of the patient to have a child. So I would say that the next time you see a ectopic pregnancy, instead of just removing the tube, doing a salpingotomy, it's a really important thing. Salpingotomy is different from salpingostomy. And ostomy, you're creating an opening. Here, you're not. You're going to cut the tube, remove the ectopic, and then you leave it open. It heals by itself, as opposed to in salpingostomy or neosalpingostomy or cuff salpingostomy, where the distal tubal end is blocked, but the rest of the tube appears okay. And on opening the tube, you find that there is rugosity is still preserved. Then that tube is worth saving, and especially in a state like this where infertility treatment is not mandated and patients would just lose both. Usually it is bilateral, so they'll lose their ability to get pregnant, and if they don't have the financial ability to have IVF, then they are forever doomed. So it is definitely something that I still do, but very few trainees are exposed, and as a result, tubal surgery is fast becoming, apart from removal of the tube, any other form of tubal surgery is fast becoming obsolete. Tubular anastomosis, thanks to my gynecology colleagues here, it's definitely gone. All the tubes are getting removed now, so there are no more tubes to be saved, sadly. So I don't blame them. There is good evidence that salpingectomy is the way to go. Yay, IVF, that's still there. So in conclusion, endometriosis, less is more. Image-based diagnosis is going to become the norm rather than the exception. Single surgery in a lifetime will be the push, and ovarian suspension, or in those cases, might decrease adhesion formation. PCOS drilling is making a comeback, maybe with a vaginal approach. Ovarian transposition is going to become mainstream. I am absolutely sure of that. Ovarian tissue cryopreservation is going to become mainstream. Uterine surgery, leiomyoma, still a major problem. The role in fertility remains confusing, and I despair that we'll never know the answer. In terms of cervical surgery, despite evidence, as I said, cervical septum is still being preserved, and we should move away from that. Vaginal surgery, newer grafts, especially artificially created vagina, would be in the future for us. And finally, tubal surgery is sailing into the sunset, and I may be the last one holding it up. Thank you for it. Say that again. Interesting. To be honest, I don't know. There are so many different fish out there. I'm a vegetarian, and I honestly, when I heard of that, and I said, "Is this even available in US?" Yes, it is. Plastic surgery uses it quite a bit. I think it causes the least, white pig and not anything else, right? I mean, for transplantation, humans are closest to pigs in terms of organ, and we are able to take that much more readily than other animal parts. So similarly, I think tilapia skin must have. But it's an excellent question. I should look it up and email you. Hi. I think Dr. Cooney wanted. Oh.
Raise your hands. I was curious about ovarian transplantation and cryopreservation in oncology patients, of course, and thinking about how practical that is like today. So we have a 29-year-old who's getting radiation therapy, needs to start in treatment in a month. Is that something that can be done? What does the patient need to go through to get that accomplished to then continue to have ovarian function?
Excellent question. So again, because this is such a broad talk, I didn't go into the depths of it. A patient with leukemia, for example, you wouldn't want to do ovarian tissue cryopreservation in that, because the fear that leukemic cells are there and they're going to reseed the patient with that. Patient with ovarian cancer, you don't want to do that either. But there's a patient with, say, endometrial cancer, and you're going to remove everything, then this is a ideal patient where you could go and ovarian tissue can be harvested, and I have done that. I have mentioned this before. I used to work closely with the oncology department a lot more when I was in Rochester than here for some reason. So I used to routinely go, and we would also, we had the ovarian tissue cryopreservation facility there. Here, the practicality of it is the sectioning device and the device to actually hold the tissue, as opposed to oocytes and sperm, is different, and it is available from Japan. It is not FDA regulated here, so you have to go through a IRB process. So it should be under a study in any institution to be able to do that. So I haven't just done that because there is no real demand, but if there is, then we would move forward with that and do that. But yeah, very much possible. We just, you have the surgery scheduled, we come in, and I do the harvesting of the cortex, and the critical thing is the embryologist comes in as well, because they section it, so it has to be thinly sliced at an even, and that's why they have a specific microtome for that. It'll be sectioned immediately, fresh, and then it'll be snap frozen and then sent off. Nice question.
Yeah, just a comment and then a question. So we are not, just to say it again out loud, we're not currently set up to do ovarian tissue cryo here. I have a folder of a bunch of IRBs and protocols and all of that, but it's just a lot of work. So if someone really needs it, not to be sending people away from here, we do send them to Northwestern, but it's a major goal of ours to be able to get it set up. We just haven't yet. And
That's the only thing we don't do.
it's the only thing we don't do. Yeah.
Just so many priorities, and it is just to go through IRB and get all that done.
Yeah. And then to try and get you some referrals for tubal surgery. So when someone, one of our generalists does an HSG or something, and they see that there's some type of distal tubal disease, like what are you looking for? How would you want people to refer patients to you, or when for surgery?
Excellent question. I mean, when somebody has a retort-shaped, the classic appearance in the HSG, that is a foregone. I mean, that's extremely unlikely that we can save a tube like that. But if it is distal tubal occlusion with even what seems to be significantly bad for you, I've frequently been impressed at how much of the tubal rugosity can be still preserved. And these patients have, yes, they have a higher risk for reocclusion, number one, higher risk for ectopic pregnancy, and I counsel these patients for that. But if that's what they want, rather than a bilateral salpingectomy and IVF, which is definitely a viable alternative, then we offer that. But don't go by just the appearance on that. You have to go in and open the tube and look inside the tube to decide whether it's a savable tube or not.
Thank
So the short answer is by looking at the HSG, unless it's like the classic, the old, like huge ram horns of both tubes, then obviously it's not worth saving, but anything else is definitely worth looking at if that's what the patient wants. Because even those patients, I would have, even if it's just a mild distension of the fallopian tube, I would offer the patient bilateral salpingectomy and IVF as an alternative. It's a viable alternative.
Great. Well, I don't want to cut into our M&M time, so thank you so much for
Thank
your
you.
presentation today.